So another thing I want to let you guys know about, which most of you do know, I am a triple negative breast cancer survivor. So this show is super important to me. We do it every year. This is our 6th year. And I am alive today thanks in part to Dr. Joyce O'Shaughnessy, who is my oncologist down at Texas Oncology at Baylor-Sammons Cancer Center. She's one of the lead triple negative breast cancer oncologists. People know about her all over the world. So I'd love to bring her on right now if she's available. Is she there, Dave? How you doing?
Hey, April.
It's great to see you, girl.
Hey, it worked.
Hey, success. She's here, remote. We're so happy to have you again, Joyce. Thank you for being here.
My pleasure.
Well,
very nice place you got there.
Oh, thank you. Yeah, they can kind of make people look good, can't they? Well, before we get started, the thing that I think is really cool about you is the background. I know we talked about it last year, but I know we have a lot of new people joining us today. First of all, everybody, this is Dr. Joyce O'Shaughnessy again. She's a oncologist in triple negative breast cancer, is her primary field. But I was so intrigued when I learned your background and what drove you to get into the oncology field. So if you wouldn't mind, take a few minutes here and share that with our people watching tonight.
Yes. Well, as is often the case, sometimes it's tragedy, that leads people to various choices in life. And I was the eldest of 4 girls. And when I was age 14, my 5-year-old sister, the youngest, I was the eldest, she was the youngest, was diagnosed with leukemia. And that was back in 1970. We lived in the Boston area. So for 5 years, she lived with the leukemia and went back and forth from Boston Children's Hospital and participated in a lot of clinical trials. Because even back then, children always participated in clinical trials. All of their care was in clinical trials. And,
wow.
That was really the earliest stages of being able to do anything. She lived 5 years, which is rather amazing. But she died at age 10, and I was in college. And so those are important developmental years. I was in high school. And so I took college, Holy Cross College in Worcester, Massachusetts, because it had a strong pre-med program.
Right.
And so I decided to do medicine, because of my sister's, my family's really ordeal with her illness. And then oncology always was very, very compelling to me, because I actually in college, after she died, I started research work then. I was able to take my senior year and completely dedicate it to cancer research.
Wow.
So I started getting into it right away. It was, it was just a sad thing for our family. So
right.
Yeah, so I was driven into leukemia research at a young age, and then I found breast cancer after my fellowship. And so, but it's been fabulous to combine, trying research to try to understand the disease. And as you said, my area of research is triple negative breast cancer, and then of course taking care of women and men with breast cancer 50% of my time.
Wow, that's amazing. I just love that story, because people can really relate to that. So many people watching right now have been affected by some kind of cancer, either in their family or a friend. And it's just something that people can really relate to. And when you see a doctor or an oncologist, you don't really think that they have, you're not thinking about the passion that drove them there. You know what I mean? Yeah, I think a lot of us out there are just like, oh, well, they just wanted to make a bunch of money. You know what I mean? They don't think that they actually had a passion behind it. So I freaking love that story, and I appreciate you sharing that with everybody. Last time we met, you gave us kind of an update on a lot of the research, and when we were able to donate some this year down at Baylor-Sammons Cancer Center to the research and trials that you guys are handling, which I'm just going to plug that we donated $40,000 this year, this week, in fact, to the research and trials that you're doing down there. One of the things that you brought up that I thought was so cool is about the genetic testing and how much that's changed, right?
Mm-hmm.
And in 2010. I feel like I was just tested for a couple of things, like
right.
just a few things in 2010, and then that just kind of grew, and there's more and there's more. So the two questions I had is, how many different things can be tested for now? And then I would love you to talk about the changes that happen with the government and the pricing for that and all that. Tell us all about that, if you could, for a second.
Yeah, it's very, very important, April, because it's something that really has become so affordable now that women can and men can easily avail themselves of genetic testing. Yeah, when you were initially diagnosed, we had just BRCA1 and BRCA2. The very famous Angelina Jolie gene, which of course is so empowering because you're able to have preventative surgery with double mastectomy, removal of the ovaries, because there's such a high risk for breast and ovarian cancer. There's also a very high risk with BRCA2, and so if you know about it, women can start at a very early age having MRIs, and once they're finished childbearing, if they have a family or what have you, then they could have preventative surgery.
Right.
But now there are pretty routinely 30 genes that are tested for, and in some panels 50 genes
Wow.
that are tested for. There are more than 10 different genes that can raise the risk of breast cancer. There are 6 different genes that can raise the risk for ovarian cancer. But also these panels test for high risk for colorectal cancer, pancreas cancer, thyroid cancer. And the bigger the panel, the more the cancers they test for. Now, it used to be that this testing was many, many thousands of dollars,
Right.
when you were tested, April. And the Supreme Court ruled that genes themselves, even genes that became mutated in human beings, were not patentable. And so that was a big deal because now we have multiple companies that are doing the genetic testing, and some of them are excellent, and the prices come way down. They can range just $250 now, or
So amazing.
$75. Different companies, and the results are excellent. And so I say to my patients, let's see if insurance will cover this for you. And at Baylor-Sammons, we have a very strong genetics program. It's on the 7th floor of the cancer center, and it's 214-820-9600. And you just call and you can go in and talk to the genetic counselors and see if genetic testing is right for you and your family. But they'll find out. The genetic counselors will find out if insurance will cover it.
Yeah.
And if so, what the out-of-pocket would be. But people can just go outside of insurance, or if insurance won't cover it, they can just sometimes it's just cheaper to just pay it out of pocket, basically, with regard to co-pays and such like that. So it really is it's very empowering. That information is very empowering. Now, I do always want to emphasize these are very rare genes, actually. People usually have to have, not always, but usually have to have pretty strong family histories, for there to be anything found. And honestly, unfortunately, there were still situations where there's a very strong family history, but we still haven't found the genes yet. Okay, so
Well, yeah,
at the end of the day, you'd really got to.
Yeah, we haven't found any in me so far, and I think I've had the latest testing, so we haven't found any gene associated with that. I want to remind you, if you don't mind, could you give us that number one more time, and our social media team, if you guys make sure we put that in the comments for our viewers to see that. What is that phone number again?
214-820-9600. That's the
Great.
genetics program at the Baylor-Sammons Cancer Center for breast and ovarian cancer. Like I said, the testing does test for other things, but particularly breast and ovarian cancer. But there's a lot people can do, but a lot of proactive with regard to breast MRIs, 3D mammograms. With ovary cancer, unfortunately, we don't have any surveillance. We can't do blood tests or ultrasounds or physical exams to find ovarian cancer at a early enough stage to be curable. So women who have a gene that raises their risk for ovarian cancer after childbearing, they should have their ovaries removed, or if they're not going to be having children, usually around 35 to 40 years of age. But for example, if somebody comes from a strong pancreatic cancer family, then you start MRIs. We have a surveillance program for pancreas cancer at the
Wow.
Baylor-Sammons Cancer Center, and as UT Southwestern does, and other centers
Sure.
as well. UT Southwestern has very strong genetics. I mean, thankfully, it's really in most of our cancer centers all across Dallas. There are strong genetic programs. So, and it's something that you don't have to. Your regular doctor could order it for you as well.
That's so
basically.
cool. That is so awesome. Yeah, I had no
Yeah.
idea that your regular doctor could do that. That's so awesome. I want to make sure that I don't miss. I've got a lot of questions that our breast cancer survivors who are going to be joining us tonight. I wanted to be sure and get some of their questions in that they submitted. Since they're going to be on the show today, I wanted them to be able to hear the answers that you have and be able to get these questions in. And along the lines of the genetic testing, Becky Brewer, who's going to be joining us here in just a little bit, she's actually our next guest, coming on around 8 o'clock. She says, with the triple-negative breast cancer, what testing do you recommend for genetics? And I think we just kind of went over that because you were saying basically the whole thing.
Panel.
Yeah,
the whole panel,
yes. Right.
Panel.
And then she says, and all the markers like PDL1 and androgen receptors, et cetera, so we can tailor our treatment options. Now, this is a completely a new question for me. Like, she's in a lot different situation than I am, so I'm not even familiar with these things are. So if you could expand upon that and answer that question for her, that'd be awesome. Sure. We're all like, I think everybody watching and myself were like, androgen receptors, PDL1, what is that, and how would that affect her treatment options? So
we are all familiar with estrogen receptor. About 75% of breast cancers are fed by estrogen, and they have this protein called the estrogen receptor, and that's what you block with pills such as tamoxifen, for example. Well, triple-negative breast cancers, maybe about 20% of them, April, don't have estrogen receptors, but they have androgen receptors, and androgens are the male hormone, testosterone. We women make a little bit of the male hormone, testosterone, and about 20% of triple-negative breast cancers have enough of the androgen receptor that the cancer might be fed by it. Now, it is not approved by the FDA to block the androgen receptor. However, and this is really only in the context of women with metastatic triple-negative breast cancer, that's metastasized to the bone or, vital organs or something. There are some women that can benefit from androgen receptor inhibitors, such as bicalutamide or enzalutamide. Those are two that have been tested in clinical trials.
Well, and Becky, who's asking the question, hers has become metastatic. So that's definitely what's driving that question. So to that point, it sounds like there's some options that she might be able to look into based on that. Is that
yes,
right?
and it's very easy to get the cancer tested for the androgen receptor. Really, any pathology laboratory can do that. And if it's strongly positive, not just weakly positive, it's strongly positive, that is an option. Now, another option that Becky is talking about is testing, again, very easy to do. It's just looking for the protein. Pathology laboratories can do it, looking for a particular protein called the PDL1, programmed death ligand 1. Now, that's very important because we're expecting any month now, in the next few months, our first FDA approval for immune-based therapy, therapy for metastatic triple-negative breast cancer. And the first drug that will be approved is by Genentech Roche. The trade name is called Tecentriq, and the generic name is called atezolizumab, Atezo for short, or Tecentriq. But Merck has another one right behind it that'll also be approved by the FDA very likely. We're waiting on the results on that here now. That one's called Keytruda, and the generic name is pembrolizumab, Pembro for short, or Keytruda. But what we know with regard to the Tecentriq is that it only works in the 41% of the metastatic triple-negative breast cancers that have the PDL1 protein.
Wow.
So, there's 41% in the clinical trials. They were testing all the triple-negative cancers for the PDL1, and 41% had it. So everybody got the Keytruda in the clinical trial, but it only worked for not the Keytruda, the Tecentriq in the clinical trial, but it only worked for the 41% that had the PDL1. So the Merck trial with Keytruda is right behind it, where we should have those results by June. Wow. So that's very definitely an option, because now with those results out there, we're being able to get those medications for patients, even though they're not FDA approved yet. We still have been able to get them for patients either directly from the pharmaceutical companies or through insurance. Now, the other thing we're waiting for that's very, very important as well, in June, we're waiting for results of clinical trials for women with newly diagnosed breast cancer, triple negative, and before they have their surgery. So before, the new approach really, April, different than you had, is to give the chemotherapy first, before surgery. And we're really hoping and praying that the clinical trials that will come out in June will show us that adding Tecentriq or adding Keytruda to the chemotherapy before surgery will lead to more ladies going to surgery and having no cancer left. Nothing in the breast, nothing in the lymph nodes, and that is pretty close to almost tantamount to being a cure, about 95% or so.
Wow, 95%, man. Just think of that. That's so crazy.
That would be incredible.
And that's one of the things that I love about talking to you each year on this is that it's so important that people realize that there's hope, that you guys are working constantly, like nonstop. And to hear 95% when it comes to this is just flipping amazing, so exciting. And I know that all that, the other good thing I want to say is there's a lot of big words you had in there, man. So I'm really glad we have replay options on this. So later, Becky, when you're watching, you can watch this again and really absorb a lot of that stuff that Dr. O'Shaughnessy just said, because that is awesome stuff. Wow. Doc, and I know one thing I want to plug real quick, and I have a couple other questions for you, is the importance of doing the genetic testing as a triple-negative breast cancer survivor. If you've been diagnosed with triple-negative breast cancer, it's so important to get that genetic testing done, because it helps the treatment and what you guys need to watch for and everything like that. Like with me, I know you've said over and over again, exercise, low-fat diet, genetic testing, those things are really what just really resonate for me. And knowing that, like, if you found one gene, that relates back to breast cancer, a lot of times that relates to other cancers, and then you can monitor that part of your body or take preventative action. And that's why it's so important, right?
Right, exactly. And for ladies that have metastatic triple negative, if a gene is found, a BRCA1 or 2, there's also a directed therapy for that. The PARP inhibitors are FDA approved. There's 2 of them now that are approved for women with metastatic breast cancer that have a BRCA1 or a BRCA2 mutation. And now they're moving those PARP inhibitors into the treatment of early breast cancer. So you're right, there are indeed therapeutic implications for women who already have a breast cancer, but it really is, it's very essential to know about those, April. You're absolutely correct.
Very cool. Yeah, thank you for that. Hang on one second, Owen. Yeah, I don't even have my glasses on, so hang on one second.
I can ask her.
Yeah.
On the mic.
Yeah. Dave's got a question. Dave is our producer. Everybody, again, I want to give him a big shout out. Y'all give it up for Dave Curley.
Thank you. Doctor, I recently read an article about some researchers in Israel that think that within the next couple of years, some of the ways that they're developing stuff, that there will be a full cure for cancer across the board. Have you read on any of that? Do you have any insights on that?
Yeah. Dave, that was one of those things that actually made a lot of us in the oncology world, we had some consternation over that. And if you Google that up, you'll see a little bit of backlash against that, honestly, because it's just in the mice so far. And, we have a saying of the mice there's more and more cures in the mice, but truthfully, there was so much hype around that particular, a set of experiments. I mean, they're very, very promising in animals, but truthfully, until you get into people, until you're into women in clinical trials, we got to be careful. I mean, we had, our phones were ringing off the hook on that one. And, it's just a tough thing to do with people that are really, watching the news on a daily basis, because as April said, there is so much going on. Now, having said that, I just, we talked about the immune-based therapies, and I happen to be aware of another small clinical trial that I can't really say a lot about because the information isn't public yet, but it's adding a second immune-based therapy to the ones I was telling you about, the Keytruda or the Tecentriq, some of our now standard ones. And, I'll tell you that the results are looking promising. Now, this is in women, with metastatic breast cancer. It's just a small study, but gee, I think it's kind of intriguing. So, the Israeli folks are doing very good work. But, and I really do think we're going to see some major breakthroughs. I think triple negative, with regard to immune-based therapy, triple negative will be the first place it does come. Yeah. My own area of research is for the women the 95%, April, those are the ladies who go to surgery and they have no cancer left, okay?
Right.
Well, then, of course, you want to get everybody to go to surgery and have no cancer left, because right now it's probably, maybe 55, 60% of ladies, with the best therapies we have. Now, we're hoping the immune-based therapies will get that up to 70%, but still, there's a group of ladies that don't have it there. And my research is to try to change the nature of the cancer with a separate treatment that actually gets it ready. It primes it. The word is primes it to be able to then much better respond to chemotherapy and to immune-based therapy. Okay. Yeah. So and I'm not the only one doing that. There's a lot of people doing that. So those are the kind of thing, Dave and April, I really do think that we will be seeing breakthroughs, but unfortunately, we have to be honest too that things by and large are step by step. It's incremental, and truthfully, you never know where the next breakthrough is coming from, basically.
Yeah, you're right, and I think that's great, and that's one of the main reasons I love talking to you every year is right from the horse's mouth is the best way to get the information, and the immunotherapy is always exciting. You've had me excited about that since day one. Courtney had a question. We were talking about the BRCA gene, and she, I believe, is BRCA1 positive, and she was wondering, is there a link to colon cancer through that gene that you're aware of?
That has been a debatable point. Whether or not there's an association, sometimes the research has said yes, and sometimes the research has said no. I think it's really unknown. Certainly, what's going to happen is BRCA1 and BRCA2, for that matter, they're very large genes, and we don't know yet. We don't have this figured out, but it's going to depend on where exactly that mutation is at. Whether some families are more prone to ovary cancer, some are more prone to only breast cancer. They'll never get ovarian cancer. We don't know that yet. Okay. So what we do is we go by family history. So if there's a family, where it's known, for example, there's BRCA1, and that side of the family where the BRCA1 has come from has colon cancer in it, for example, then we certainly would make the assumption that there could be a relation in that family with colon cancer. Now, my own recommendation for my women who have a BRCA1 mutation is to get the first colonoscopy. Don't wait till 50. Get it at 40. Get it at 45. Don't wait till 50. Just get it. And I think it's prudent to stay with it every 5 years rather than go to every 10 years, even if it's clear, because it's not clear. I think at the end of the day, there could be somewhat of an association, not a strong association, but somewhat of an association.
Yeah. Good. Well, I know that was of great interest to her, and it makes sense that there's been some kind of a debate about it, why she's asking. So that's really good information. Exactly. And your point is stay true to that testing that your doctors usually recommend as a cancer survivor anyway, for the colonoscopy and what have you. We have a question from somebody watching the broadcast, and I'm going to read it verbatim. Will there be a TINAGL1 trial, TINAGL1 trial? Does that sound right? Are you familiar with this? TINAGL1 trial. Are you familiar with this, Dr. O'Shaughnessy?
I'm not. Okay. I'm not familiar with that particular therapeutic or gene.
And thank you for the question. Guys, keep them coming. So another question I had from Becky was that she says that there's so many trials out there that are available for metastatic breast cancer patients, but finding them and navigating the inclusions and exclusions can get so overwhelming. What is the best resource for finding the trial that fits? Is there a registry or a website that you would recommend for that?
There's a website, an app called Smart Patients, and they do a good job. They've made the trials, I think it's a simpler format than clinicaltrials.gov. Mm-hmm. Breastcancer.org also does a very nice job with the trial listing and the trial search, okay?
I've seen that. I've run across that site several times. What was the app called one more time? And our social media team would plug it in there.
Smart Patients.
Smart Patients, got it.
Smart Patients. And they do a nice job. They really break down, the key eligibility criteria. The other thing I'm going to mention is there is a company called Perthera, P like Paul, E-R-T-H-E-R-A, Perthera. Uh-huh. And your doctor just orders that your tissue, if a woman has metastatic breast cancer, actually this is for cancers across the board. This is not just for triple negative, and it's not just for breast cancer. It's for any person that has a metastatic cancer. The Prothera company will take, with a doctor's order, they'll take over and actually send your tissue. They'll get your tissue. You have to sign permission, of course. Send your tissue to various genetic testing laboratories. They will get the results, and they have a molecular tumor board, and they're experts. They're experts at what these molecular test results mean, and then they will match what they think are the best clinical trials for you. And there's no cost. Wow. They do not charge the insurance company for their Prothera services. The insurance company gets charged for the genetic testing, but they actually don't charge the patients, for this service. And they don't charge the insurance company for their service, but it's called Prothera.
Wow,
and
that's amazing.
Yes, because a lot of people will get these genetic tests, on their tumor, or sometimes there's genetic tests on the blood as well to see what mutations are in the bloodstream when you have metastatic cancer.
Right.
But then these mutations comes back and like, oh gosh, well, what does this mean in terms of what clinical trial would be helpful for me? And sometimes the doctors can help with that, and sometimes they can't. Right. And so this service called Prothera is one that can be helpful to people.
That is so freaking cool. It's so good to hear, too, because I could only imagine trying to navigate that. It has to be really difficult. It looks like we got another question from someone on the stream. Let me hear about it.
Does reoccurrence change if a patient is BRCA1 and BRCA2 negative?
That's the question.
Does reoccurrence occur if the patient is BRCA2 or BRCA1?
Change.
I'm sorry?
Change.
Reoccurrence change.
Yes. Is it change? Is there a difference? Is there more risk? No, thank goodness.
Okay,
no,
good.
Women whose breast cancers are BRCA1 or BRCA2 do not have a worse outcome than women who do not have that. So whether you have a mutation or not does not make any difference, thank goodness.
Wow.
So there's not any kind of a worse outcome at all.
Right, great.
It's the same. It's the same.
Yeah, cool. I don't want to miss, I've got a couple, I know you've got a jet here in a few minutes, so I've got another question here from Courtney. Courtney's going to be on our show here and next up at 8 o'clock. She's a triple-negative breast cancer survivor with BRCA1. She says the research and one of the drugs that she was given, she did a trial actually, was called Baylor-Sammons.
Yes.
And she was curious to know about other clinical trials this drug may be being used for, since it's a PARP inhibitor.
Yes. I'm familiar with that trial, Courtney, and that trial, the trial that combined the veliparib, which is a PARP inhibitor, with the chemo drug carboplatin, when added to the other standard chemo drugs, did show a very nice improvement, in the percentage of women who went to the operating room and who had no cancer left. Again, it didn't do that for everyone, but it was a higher percentage, bringing the PARP inhibitor there. And there's a subsequent trial, though I'll just tell you, there was a subsequent trial that showed that the addition of the veliparib, the PARP inhibitor, to carboplatin, a chemo drug, was not additionally beneficial, so that if women get the carboplatin, then they really don't need the veliparib because it didn't add additionally. But what's very interesting, for example, is that one of the PARP inhibitors that's recently been approved by Pfizer, called talazoparib, we call it Tala for short, the MD Anderson team has shown that just getting the PARP inhibitor, forget the chemotherapy, for 6 months, had a high chance of the women going to surgery and not having any cancer left. Now, again, it was a small trial, just 20 women. So now MD Anderson is doing a much larger trial in BRCA1 and BRCA2. Right now, they're focusing on triple-negative breast cancer patients, but there were some women with estrogen receptor positive BRCA1 or BRCA2 that also benefited. So the PARP inhibitors may end up for down the road, possibly, we can hope, taking the place of chemotherapy, but it's too soon to know that yet. But the PARP inhibitors, the most important thing about PARP inhibitors is there's a clinical trial going on called the Olympia trial, and it's women with triple-negative breast cancer, actually or ER positive breast cancer, they have a BRCA1 or BRCA2, and they finish up all their standard therapy, chemotherapy, they can be on anti-estrogen therapy, chemotherapy, radiation, surgery, and then they take, they're randomized to take the PARP inhibitor olaparib, which is called Lynparza, or a placebo for a year.
Yes. Sorry about that, Dr.
No, not at all.
Yeah, and I was going to say that it's fascinating because all the different, like you're talking about chemo and inhibitors and receptors. It's like, wow, it's like so much information. It's amazing, and I can't wait to watch it over again because it's like a lot to absorb. It's such great information, especially for the ladies asking this question, and a lot of the ladies watching. I'm in a lot of different triple negative breast cancer support groups on Facebook. And so there's probably a lot of them watching right now, and this is so incredibly helpful. I don't know if we have time for another question, Dr. O. It's your call. Are you sure? Okay. Hang on one second. Oh, okay. Yeah, we're short on time, so pick your favorite.
Is immunotherapy working well for triple negative breast cancer?
Oh yeah, she actually went over that. So yeah, let's hop to another one because immunotherapy is killing it, according to Dr. O. And we can watch the replay if you join late. She gives a lot of information about that.
What is the reoccurrence rate for patients that have tested positive for the CHEK2 mutation?
We don't know what the
I'm sorry, and who is the question from? I want to be sure and holler out at those folks.
Alice Kale.
Alice Kale. Great. Sorry, go ahead, Dr. O.
So CHEK2, just so everybody knows, CHEK2 is another normal gene that can be mutated in families, and it can raise the risk for breast cancer and colon cancer, okay? So it's not very common, but it's there. I have a number of women who have a CHEK2 mutation. We do not have any evidence that women with a CHEK2 mutation do any worse, than standard type breast cancers. Most CHEK2 mutations are estrogen receptor positive, but we do not have any evidence that those women have a worse outcome at all. It's kind of like the BRCA1 and BRCA2. As long as women get, the standard therapy, they should do well. But we don't know. I will say I have not seen a specific study for looking, culling out the CHEK2 positive patients to look at their cure rate, from breast cancer, for example. But I have a number of such women in my practice, and my gestalt is that they have the same outcome as other women. And they should, because BRCA1 and BRCA2, they're all in that same DNA repair family. They're all very similar, and we know that the BRCA1 and BRCA2 women do the same.
Wow. That's great information, too. And see, I'm hearing about all these different genes. Like, I did the breast next testing.
Yes.
Yeah. And they had all the different names. The most common one, obviously, that you hear about is the BRCA one, because that was the first couple of ones to ever be tested for, right? But there's all these different ones, and so it's like every time somebody's bringing up one, or I'm reading over here, or I'm hearing it back, I'm like, gosh, it's just so much stuff. I'm just going to give you, if I know you got it run, but I think you have a really great message. Whenever I ask you, what is the most important thing that you'd like to pass on to women going through triple negative breast cancer, I would love you to just give that, and you can make it brief if you need to, however long you want. Just give us your spiel, because I think it's always really important to hear that from you.
I think, and this is really true right across the board for anyone with breast cancer, including triple negative, but all breast cancers, I think there's actually a lot that women can do, for ourselves, to take control of our health. And because there's prospective studies that have shown a higher cure rate for women who exercise just moderately, such as moderate walking 3 hours a week. It reduces the risk of dying of breast cancer by 50%. Wow. Now, that is just huge, In women with triple negative breast cancer, low-fat diet, as you said, those women lost 6 to 8 pounds, not that much. They were eating a low-fat diet, and there was a 50% less chance of recurrent breast cancer. 50%.
That's huge. It's huge, man.
We know that a 10% weight gain with estrogen receptor positive breast cancer can increase the risk of recurrence. There's some emerging evidence. It's not nailed down 100%, but there's some emerging evidence that maybe a 10% weight loss for women who are overweight or obese, that a 10% weight loss, And keeping it off, very important, keeping it off can decrease the risk of recurrence. And then lastly, low alcohol, less than 1 drink a day. When you're a breast cancer survivor, alcohol raises up estrogen levels. It's a carbohydrate. It raises up insulin levels. It's also wounding to any dormant cancer cells. So less than 1 a day, 3 to 4 a week is safe, So those are the 3 things that I believe are proven at the highest levels.
And those are big numbers, man. Yeah.
Difference.
Yeah.
Big, April, big.
Yes.
And just in my experience, I believe in it. I believe in it from my own experience.
Yeah. And like I said, coming straight from the horse's mouth is so important. And I don't mean to keep calling you a horse. But seriously, guys, when you hear this straight from somebody that's in the trenches of triple-negative breast cancer study, so important to hear those words from her. I repeat that all the time, Dr. O. Anytime anybody asks me anything, I repeat it over and over because I believe it's coming straight from you. You know better than anybody, and those numbers speak the truth. So right there, guys, it's something to really listen to. Dr. O, thank you so much. I know you've got a busy schedule tonight, so thank you so much for joining us this evening. We
My
so
pleasure.
appreciate you.
Thank you so much, April. Thanks, everybody. Good night.
I love
Bye-bye
you, girl.
Now. Bye-bye. Thank
care.
you. Bye-bye now. Bye.
Guys, wow, she's a freaking rock star, man. She's killing it all the time.